Hello everyone, and thank you for joining us for today's AAKP HealthLine webinar. I'm Jerome Bailey, AAKP's Director of Patient Engagement and Advocacy. On behalf of the American Association of Kidney Patients, we're excited to welcome you to this special HealthLine webinar in recognition of the upcoming National Phosphorus Awareness Day. Today's conversation is an important one. We're talking about phosphorus, something many people living with kidney disease hear about often, but don't always fully understand until it becomes a problem. This webinar is part of AAKP's National Phosphorus Awareness Day, observed on April 5th. Our goal is simple: to help you better understand what phosphorus does in your body, why it matters, and what you can do about it in your day-to-day life. Over the past year, tens of thousands of patients, care partners, and healthcare professionals have engaged with our Hidden P campaign. If you haven't already, we encourage you to visit the hiddenpinKidneyDisease.org, where you'll find educational tools, patient stories, and practical resources you can actually use. We hope today's session gives you information you can take back to your care team and apply right away. Before we get started, we'd like to share a brief message from our National Phosphorus Awareness Day sponsor, Advocacy. Welcome back, and thanks again for being with us. Let's get into it. Phosphorus is essential for the body, but when you're living with kidney disease, too much of it can quietly build up and cause real harm. We're talking about effects on your bones, your heart, and your overall health, often without obvious symptoms early on. That's why this topic matters. This isn't just about lab numbers, it's something that can directly impact how you feel and your long-term health. You'll hear us refer to phosphorus as the hidden P. That's because it often shows up in places you don't expect, especially in processed foods, and its effects aren't always obvious until damage has already started. That's also why April 5th, or 4.5, represents the target phosphorus level many kidney patients aim for. Today, you'll hear from experts and patient leaders who will help break this down in ways that's practical and real. Before we move forward, I do want to briefly mention something important that's happening right now. I'm referring to a 2024 decision made by the Centers for Medicare and Medicaid Services to move all oral-only therapies, including phosphate-lowering therapies, or PLTs, into Part B of the end-stage renal disease Medicare Prospective Payment System, commonly known as the bundle payment system. AAKP strongly opposed the 2024 CMS leadership and staff decision as anti-patient, believing that this decision would interfere with kidney professionals and their ability to exercise their best expert medical judgment on how to tailor the right medicine at the right time to the right patient in order to improve patient health and quality of life. We also believe the 2024 CMS leadership and staff decision was contrary to the 2019 executive order on advancing American kidney health and the goals of keeping kidney patients as healthy as possible, avoiding preventable complications, and ensuring transplant readiness. To better understand what this looks like in the real world, we conducted a flash survey of patients, care partners, and healthcare professionals through our Center for Patient Research and Education. We wanted to hear directly from those affected regarding any issues they may have experienced related to patient choice to phosphate lowering drugs, including barriers to access or delays. What we're hearing is critical, and it's helping guide our advocacy efforts on your behalf. To talk more about this, I'd like to introduce AAKP's Vice President and Chair of Policy and Global Affairs, Paul Conway. Paul brings a unique perspective. He's a former dialysis patient, a 29-year transplant recipient, and a national leader in patient advocacy. Paul has been recognized for his advocacy work with several national awards, including the President's Medal from the American Society of Nephrology and 2 Presidential Service Volunteer Awards in 2020 and 2022. Paul has served in 4 U.S. presidential administrations, including as Chief of Staff for the U.S. Department of Labor. He was selected by the FDA to serve as the inaugural chair of their Patient Engagement Advisory Committee and has served on the American Board of Internal Medicine's Nephrology Specialty Board, as well as multiple CMS technical panels related to dialysis quality improvement measures. Paul, welcome. I turn the program over to you.
Thank you very much, Jerome, and thanks for the hard work that went into this webinar and so many other efforts to educate folks on what is going on the landscape with phosphorus management. As a kidney patient, I've had many challenges over the years managing phosphorus, especially when I was on dialysis. At that point in time, innovations did not exist that would made it easier for patients to limit their pill burden. But now that there are innovations out there in the marketplace, denying access or creating barriers to access is something that AAKP takes quite strongly. And when CMS decided to go ahead and include it in the bundled payment system in 2024, just like Jerome said, our organization stepped forward and took a strong stand because we were very, very concerned that professionals who take care of kidney patients, and most importantly, kidney patient consumers, would have a disruption in the continuum of care, especially for those that have a dependency on new therapies because old therapies simply have not worked. And I think for the folks that are listening, you know exactly what I'm talking about. Pill burden is a serious issue. So in our survey, we went ahead and we got insights from patients and professionals. And I think you'll find them very interesting because many of the things that AAKP articulated to CMS prior to the implementation of this policy on January 1, 2025, have rung true for both professionals and patients. Let's go ahead and take a look at some of the questions and some of the comments and insights we got back. One of the first questions we asked is, do you or a loved one currently take one or more phosphorus-lowering therapies to help manage your serum phosphorus level? 46% said yes, 51% said no. But it gives you an idea across the kidney population, especially those who are on dialysis, how many do depend on PLTs. We also asked that AAKP had been surprised to learn that some federal officials are largely unaware of the quote-unquote pill burden patients endure with conventional approaches to managing their high phosphorus. We asked, can you tell us how many pills per day do you or your loved one take to manage their meals and phosphorus? And here you go. You have 1 to 9 pills taken by 70%, 10 to 15, 22%, 16 to 20, 7%, 21 or more, 3%. The reason why this is important is because if you take that number 9 per day, per week, and then you do the extrapolation across a year, you're talking about thousands of pills in addition to other medicines that patients have to manage. And you have to manage this 3 times a day with your meals. A lot of the federal officials we talked to had absolutely no clue that this adds to the burdens of kidney patients who are working really hard to stay on track with so many of their other pills and medications. They simply did not know what goes on in the daily life of a patient. This was in regard to implementation. On January 1, 2025, with very little engagement with patients or the kidney expert community, CMS moved forward and implemented this new payment policy that restricted patient and provider access to new oral-only innovations in phosphorus-lowering therapies. So we asked patients, do you believe federal agencies like CMS should act with more transparency and involve more patients and kidney experts in decisions impacting kidney health and patient outcomes? Not surprisingly, patients and medical experts said, yeah, we do think there ought to be greater transparency. 90% said that. Only 3% said no, 7% were uncertain. But what is clear is this: CMS took action that negatively impacted patient access to PLTs without involving the stakeholders that are most important, patients, and without involving the stakeholders with the expertise that patients trust to care for them, the kidney experts. We just think this was bad policy and bad implementation. Here, we asked, as a patient or a care partner, generally speaking, do you believe their ability to manage phosphorus successfully has improved or worsened since CMS implemented their 2024 policy decision on January 1, 2025? This gets pretty interesting. Somewhat worsened, 35%. Significantly worsened, 35%. That's 70% are already talking about a negative impact. Stayed the same, about 10%. You see some folks saying that there's an improvement, and 10% say not sure. But the numbers to focus on are the worsening effect after the policy is implemented, and that's 70%. So on this next slide, we asked patients if they're aware of the long-term consequences of inadequate phosphorus management, including calcifications of blood vessels, bone loss and fractures, stiffening of blood vessels, heart failure, and early mortality. Those who were very aware and understood these risks, 60%. Those who were somewhat aware, they kind of knew some of the risks, 25%. That 85% number is a tribute to patients asking questions and to the medical teams who work with them who are educating patients on their risk. You had much lower numbers that were only slightly aware, but by and large, the patient community is acutely aware of the negative impact on a person long-term if phosphorus is not managed. This is vitally important to kidney patients. And then we ask patients, are you aware that inadequate management of phosphorus and the resulting impact on your cardiovascular system can have an impact on transplant readiness, essentially your ability to get a transplant, and also long-term post-transplant outcomes? Those who understood it, 60%. Moderately aware, they knew some of it, 14%. Not aware at all, 13%. And slightly aware, limited understanding, 12%. Let me batch these two sections here. For those who are aware or moderately aware, that's about 73%. Almost 3/4 of patients understood the linkage between phosphorus management, cardiovascular health, and transplant readiness. These are patients who are working every single day to make certain they stay healthy across so many different domains, but especially in terms of managing their phosphorus. Those who said they were not aware or slightly aware is about 25%. That's a lot of patients. That's a lot of work we have to keep doing with professionals and with patients to educate them so that they understand that their transplant readiness could be negatively impacted if the phosphorus is not managed correctly. These are people who especially need access to new innovations that make it easier to manage your phosphorus. And then we asked professionals this same question. We asked, since January 1, 2025, have you experienced any disruption in your ability to prescribe oral phosphorus-lowering medications to your patients? We thought this number was stunning. Yes, 61%. So those medical professionals that patients trust, 61% of them, are having problems after CMS implemented the policy. No, 28%, unsure, 11%. Again, we let CMS know this in 2024 when they first announced the policy and long before they implemented it. Nearly over a year after implementation, This is still interfering with medical professionals and their ability to prescribe the right drug for the right patient at the right time. These are some of the direct quotes that we got from medical professionals. You can see right at the top here, as a small dialysis provider, we have more limited access to phosphate-lowering therapies, especially the newer, more expensive medications. You have other professionals talking about how they had to go and substitute other types of things, cheaper alternatives for patients, and on it goes. These are just three examples of the tons of comments that Jerome and Aaron and Diana Kleins on our team have gotten from frontline providers and from patients, but especially from providers. It is a sad story. And then we asked professionals, had you recommended any changes to your patient's diet, lifestyle, or treatment plan because of issues obtaining phosphate lowering medications? 58% said yes. 33% said no, 9% said unsure. So, what does this practically mean? This means that the medical professionals that patients trust, nearly 60% of them, are having to tell patients how to modify their diet, their lifestyle, and their treatment plans because of issues related to a policy that CMS implemented on January 1, 2025. How ironic, since CMS is given the charge of managing the end-stage renal disease program and making certain that patients have positive outcomes. We think this is a sad chapter in public policy. And we asked professionals this very important question. Are you aware that inadequate phosphorus management can delay your patient's acceptance into a transplant program and impact outcomes? Well, here you have it. 80% said they're very aware of this. 13% said moderately aware. I think it's safe to say that at 93%, the medical professionals that are working hard every single day to keep patients healthy, especially those patients who aspire to have a transplant, their work has been interrupted and their work has been frustrated because they're working hard to make certain that a patient can get a transplant. And this policy has started to interfere with that. And you have 93% of the folks saying that they understand the connection between managing phosphorus and getting that patient to the point where they can get a transplant. Finally, we said, do you agree that kidney patients and the physicians they choose to treat them should have access to all new and safe FDA-approved kidney medications designed to improve patient health and decrease the burdens associated with other or older types of treatments? And here you had 98% of our respondents saying absolutely and of course. Only 1% said no, and just a few were unsure or unaware. Folks, let me just conclude by saying this. We work really, really hard to make certain that new drugs in the product pipeline from private industry that comes into the FDA, that the FDA understands the insights of patients and the real world issues that they have simply existing with kidney disease and prevailing. When new innovations come about that make care easier for the patient to be empowered and to do a good job, we believe they should have access to them. And so do the medical professionals they trust to take care of them. It's overwhelming. We need to do better. We need to keep fighting this issue that CMS interfered with, phosphorus management, through bad policy. And AAKP is not about to give up on the fight. So I hope that this webinar has been helpful to you to understand the stakes that are involved, the real people that have been negatively impacted, and the insights that medical professionals, to some risk, were willing to share about what they've gone through in terms of the difficulties of prescribing for the patients that they trust and the patients that they're trying to position to get a transplant. Thank you very much for listening. And Jerome, thank you so much for the hard work that went into this in the survey. It's just absolutely stunning to look at these numbers. And as somebody who has tried to manage phosphorus for decades, it's really sobering. And my heart goes out to all those patients that AAKP is trying to help. Thank you.
Yeah, I couldn't agree more, Paul. Paul, thank you for sharing your experience and helping put these issues into perspective. And thank you to everyone who has already participated in the survey. If you haven't yet, there's still time. We encourage you to share your experience. Your voice truly matters in shaping policy and protecting patient access. Now let's shift into the clinical side of this conversation. I'd like to welcome our next speaker, Dr. Stephen Fadem. Dr. Fadem is a highly respected nephrologist and longtime champion of chronic kidney disease education. He serves as chair of the AAKP Medical Advisory Committee, clinical professor of medicine at Baylor College of Medicine, and has spent decades helping patients better understand and manage kidney disease. He's also been a pioneer in using digital tools to educate patients, founding several trusted online resources focused on kidney health. Many of AAKP's educational materials have benefited from his expertise, including the Patient Plan series and Kidney Beginnings. Dr. Fadem has received numerous national honors for his work, and he continues to play an active role in patient education as editor of AAKP Renal Life magazine. Dr. Fadem, thank you for being with us today. I turn things over to you.
Thank you very much. It's a pleasure to be here and to celebrate National Phosphorus Day. And I would like to start by welcoming all of you. Let's begin. So today we're going to talk about phosphorus control and transplant readiness in dialysis patients. It is very important to maintain a healthy serum phosphorus level if you're a dialysis patient and if you're seeking a kidney transplant. And there are several reasons why, but to highlight, the number one reason is survival. The better your phosphorus control, the better your survival. Several studies have demonstrated this. Number two is your cardiovascular risk profile. Number three is how well you will do with surgery. And number four, after your transplant surgery, how well will your transplant do? And how well will you be able to tolerate having a new kidney? Chronic kidney disease is common. It affects about 10 to 12% of the entire United States population. And once kidney disease advances, there's no choice but either dialysis or a kidney transplant. A transplant is better. It's associated with a longer life expectancy, a better quality of life, and even lower medical cost. But there's a shortage of kidneys to go around. In 2023, the last year that we actually have full data for, that it's been analyzed for, 93,000 people were on the list to receive a kidney transplant, but only around 28,000 received a deceased donor transplant. Only 6,300 about received a living donor transplant. The wait time is 3 to 5 years, sometimes even longer. Your blood type plays a major role. Type O is the hardest to get, while type AB is the easiest to match. So what is transplant readiness? The American Association of Kidney Patients defines transplant readiness as a patient's opportunity and ability to pursue a kidney transplant when it aligns with the patient's aspirations and their goals of care. It's not just simply meeting a clinic medical checklist. It is fundamentally about your choices, what you want to do with respect to accessing FDA-approved treatments, and in particular, empowerment. So the important factors are, number one, understanding all of the choices available to you, all of the modes of therapy that you have at your disposal. Number two, removing any barrier to accessing safe and effective FDA-approved treatment that supports your ability to remain healthy and receive a transplant. Number three, to align with your life goals and aspirations. And number four, empower you through education and respect for your autonomy. Transplant readiness means that if you got a phone call that said, "Are you ready? We have a kidney for you. Meet us at the hospital. Are you ready to go?" Understanding that this is a very competitive nature when only a third of the people are going to get a transplant that are on the list, you want to be as prepared as possible. And you have to remember the transplant centers take adherence very, very seriously. So if you're missing dialysis treatments, if your phosphorus isn't controlled, is your blood pressure is too high, if you have an infection, they're simply going to go to the next person. They don't have a lot of time. They have to make some split decisions. So you have to control your serum phosphorus. You have to manage your parathyroid hormone level. You have to control your calcium balance. And you have to be adherent to all the other factors that are going to be taken into consideration when you are called for a kidney transplant. Now, no one is pretending this is easy. It's very, very hard. It's very challenging and it's very difficult. And sometimes things can be stacked against you. So let's begin by talking about a simple molecule called phosphorus or phosphate. It's a mineral which is common in just about everything that we eat. It's in whole grain bread, it's in beans and lentils, foods that are actually good for you. But it's also in red meat, which may not be the most healthy alternative. It's present in cheese, which in moderation is okay. And it's also present in soda. In fact, the pure form is present in soda. Not so good. It actually is important for your life. You cannot live without phosphorus. Every single thing that's related to energy has to do with ATP, adenosine triphosphate. In other words, to give you the energy you need to do all the things that you do in your body takes 3 phosphoruses. That's what ATP stands for, adenosine triphosphorus. So your body will have phosphorus stored, and it will use that phosphorus to make enzymes work, create proteins, cause the cells to stay perfectly in shape, to make sure your DNA is repaired, to help prevent cancer. You name it, ATP is there. If you want to run a race, if you want to walk, if you want to get out of a chair, you need ATP. Also, phosphorus is needed for bone formation, and it's eliminated by the kidneys. So when the kidneys don't work, it actually accumulates. This is called hyperphosphatemia. So what is hyperphosphatemia? The high phosphorus that you have in your body doesn't like to stand alone. It likes a partner. So what it will do, it will go into the bone and take calcium out of the bone. What does that do? It makes the bones weak so that they can fracture easily. And the phosphorus will stimulate FGF23, which is a growth factor, and the growth factor is released by the kidney to stimulate phosphorus excretion. So with milder kidney disease, your phosphorus is excreted and you stay in balance, but at a cost. FGF23 is subtly toxic. In other words, it can suppress vitamin D, which is good for you, and clotho, which is really good for you. The lady to the right, the statue, is the clotho, one of the 3 fates, and she spins a web, the web of life, that comes from ancient mythology. And this is a statue of clotho. It's in one of the great museums. And but clotho, the name in our field, is actually a molecule that helps to protect blood vessels and keep us healthy. And it's suppressed by too much FGF23. Now, the lack of active vitamin D from the kidneys also decreases the calcium absorbed from the gut, but vitamin D is also very good for you. It helps to prevent cancer, and it helps to do many, many things. And one of them is the suppression and control of the parathyroid hormone. This is a hormone in your neck, which when it's synthesized and there's too much of it, it actually continues to weaken bones. So the 2 things that are bad that can happen are, number 1, your bones become weak, and vascular calcification. This is the buildup of phosphorus and calcium combined inside of blood vessels. Now, it's different than atherosclerosis that you get from high cholesterol. This is a type of calcium that is in a different part of the blood vessel wall, and it forms almost a ring around the blood vessel wall that leads to a calcium deposit. In other words, your blood vessel becomes stiff like a pipe, and you can imagine your heart has to pump through these stiff, non-elastic blood vessels, and it makes your heart have to work really, really hard. Now, what really happens is phosphorus is actually going to turn on DNA to transcribe RNA to make collagen inside the blood vessels. Usually this happens in bone, but it's happening in blood vessels. And this is going to trap calcium. And so it's going to make the bone very, very hard, stiff like a pipe. And so when the blood vessels are stiff and the heart has to work harder, then that's going to make the heart get sicker. You're going to have heart failure because the hard-working heart is going to lead to scarring. Scar tissue is going to build up. The heart is working so hard, it's outpacing its supply of oxygen. So when it does that, it stimulates fibrosis or scar tissue formation. And you can't create enough blood vessels. All it does is create scar tissue. So the heart can't pump effectively because scar is different than muscle. Also, this scar tissue cannot conduct the electrical impulses that are necessary to propagate the rhythm throughout the heart to make it work in a coordinated fashion. So your heart doesn't pump synchronously, and when it doesn't, it goes into an erratic rhythm called ventricular fibrillation. This is fatal. Cardiac mortality is 10 to 30 times as high in dialysis patients as in the general population. So, dialysis patients and kidney patients in general, we all have to be very, very careful to try to do everything we can to protect our hearts. And there are many things we can do. I could get off on a tangent, and I won't, but I'll just say one thing. If you're not already on them, start taking omega-3 fatty acids. So how does serum phosphorus relate to transplant readiness? Well, the people that are doing kidney transplants set up a committee to evaluate whether you're qualified to get a kidney transplant. And their qualification only means that number one, you'll survive the surgery, and number two, you'll have a good outcome afterwards. That's all they really care about. So research shows that if you go through a transplant operation with a higher serum phosphorus level, you're going to have an increased risk of a delayed graft function. In other words, your transplant's not going to work very well, and it may take a long time for it to really work the way it's supposed to. And during that period of time, the kidney transplant can actually become damaged. We call the kidney transplant a graft, just like any graft. Also, if you have a low, well-controlled phosphorus before the transplant, your graft survival is going to be better and you're going to do better. Many transplant centers assess how well you control your serum phosphorus as an indicator of your overall health and management of your body sources. In other words, what you're doing to take care of yourself, because they want to make sure that after you have a kidney transplant, you're going to continue to do well. You're going to take your medicines properly. It's not really rewarding to transplant a kidney into a patient that's not willing to take their medicines. So the transplant teams feel that if you're not going to take your medicines right before the transplant, you may not take them right afterwards. And this is a very competitive environment. So taking your medicines and keeping your phosphorus under control improves your candidacy for a kidney transplant. So what is hyperparathyroidism? Well, the parathyroid glands are in your neck, and they delay that. What they do is they secrete a hormone. They synthesize and secrete a hormone that keeps the calcium and phosphorus in balance by going into the bone and stimulating the calcium to leave the bone so that it can be balanced by the phosphorus. Now, if your parathyroid hormone is too high, it can delay your transplant listing, and it can also increase a condition known as post-transplant hypercalcemia, where your calcium levels are too high afterwards. And it also can increase your risk of having a bone fracture after your kidney transplant. Some centers consider a parathyroid hormone greater than 800 to be a relative counterindication to getting a kidney transplant. And a survey of U.S. transplant programs reported that there's a concern that having a parathyroid hormone greater than 800 might endanger your graft outcome. In other words, the reason they don't want to give you a kidney transplant if your parathyroid hormone is too high is they're afraid that the high parathyroid hormone will actually damage and endanger your chances of doing well afterwards. So, with respect to transplant readiness, we want to talk about it's not just a lab value, it's not just a serum phosphorus, it includes your general well being. How do you feel? How are you doing? What is your quality of life? The transplant board is going to take into consideration how adherent you are to taking your medications. Because if you miss transplant medications, your transplant is going to reject and you're going to lose it. But controlling the phosphorus is very hard. Diet alone is very, very difficult, made for many, many people be impossible. And so many patients have to take several pills directly with their meals to keep their transplant opportunities alive. In other words, to keep their phosphorus levels in control. But it's not always easy, and some pills that actually improve the serum phosphorus may not be covered by your insurance. Hyperparathyroidism can lead to post-transplant hypercalcemia, as we mentioned before. So it's very, very important that all of these factors be controlled, but sometimes because of not getting the proper insurance benefits, it's impossible to really do a good job for yourself. And that's not necessarily fair. So in reality, 40 to 50 dialysis patients remain above target phosphorus levels and above parathyroid hormone levels. The binder pill level is at least half of our total daily pills. So non-adherence is common. Phosphate binders are the largest contributor to our daily pill burden. Adherence is a major limitation to controlling our serum phosphorus. So what about the management? What can we do? Well, the guidelines that we follow, the KDIGO guidelines, have based the decisions on serum phosphorus, calcium, and parathyroid hormone trends. In other words, people who are going to evaluate you for a kidney transplant are going to look at your trends. The lower elevated serum phosphorus is going to be considered optimal. And they're not just going to look at a single value. You may have a bad day. They're going to look at everything. So what medications do you have available? Some of the medicines are calcium-based. They're made with calcium, and the calcium-based binders will actually lower the phosphorus in your GI tract. They will bind the phosphorus and eliminate it in your stool. Sevelamer is a synthetic product that does the same thing. It too will bind phosphorus and eliminate it. Same with the rare earth lanthanum. There is also a choice of iron-based binders. There are 2 iron-based binders that can help to eliminate phosphorus, 2 that we use regularly. And there are also newer drugs called absorption inhibitors. Now, they work completely differently. They do not work on the phosphorus that's in your food. They work on the wall of your intestines so that they will restrict the phosphorus that can go through the wall. That's good news because you don't need to take these medications with your meals. You can take them in the morning and in the evening. So you don't have to stop in the middle of your meal and chew a bunch of pills or swallow a bunch of pills. But not all insurance companies want to pay for these drugs. So that becomes a problem. Let's focus on adding additives and let's focus on avoiding them because don't forget, food is something that you buy off the shelf in the grocery store or from the freezer section of the grocery store or the cold food section. If a food stays on the shelf, it tends to decay. In other words, bacteria will start eating the food, digesting it. And you can prevent that by adding phosphorus. Phosphorus works to prevent the decay of food on the shelf. It increases the shelf half-life. So it's good for the grocery store, but it's not necessarily good for you. It also acts as an emulsifier. So when you have frozen food and then you thaw it out, all the juices that have the flavor in them don't just run out. The phosphorus protects from that juice being lost. So phosphorus is also an emulsifier. It also adds flavor to food. It has a sharp kick, and it was figured out years and years ago by the manufacturers of certain sodas. And phosphorus is added to many of the dark sodas to give them a flavor. So what you want is to eat foods that have lower phosphorus. Now, a lot of meat and fish and poultry, they may have phosphorus in them, but they're good for you. So you have to eat them, but mostly in moderation. Plants have phosphorus too, but we don't digest the phosphorus as well in plants. So phosphorus is really better for you than to eat proteins in too much meat. An elevated phosphorus in early chronic kidney disease needs to be treated. So these are the things that we think about when we talk about managing serum phosphorus. So back to fairness. If accessibility to medications is going to indirectly influence whether the phosphorus is controlled, then tracking the waitlist time, the transplant rate, and the post-transplant result needs to be based on accessibility to medications and perhaps needs to be adjusted. So if you have poor insurance that isn't going to pay for your benefits, then if this is trended, it will give an incentive to insurance companies to try to do better because overall it's cheaper for an insurance company to pay for your phosphate binder than it is to keep you on dialysis and not give you a kidney transplant. So this is how we manage phosphorus today. We limit processed foods. We limit foods that are high in phosphorus. We take our pills along with meals to bind the phosphorus in food contents. If available, we take medications that directly block the intestinal wall from absorbing phosphorus. We take vitamin D to suppress the parathyroid hormone and help maintain strong bones. And some of us take vitamin K because even though it needs more research, it may protect blood vessels. What does this mean for you? Controlling your phosphorus is part of preparing your body for a new kidney. It's not just about fixing a lab number. A better phosphorus control can help shorten your waiting time for a transplant by improving your chances that the transplant center is going to consider you ready. It's going to help your bone, blood vessel, and heart health. Expanding access to novel phosphate-lowering therapies and tracking their impact on transplant access and outcomes is going to improve your health. It can also lower the cost of your care. So in summary, bone protection. We want to preserve our skeletal integrity and reduce our risk of fractures. Number two, we want to improve our cardiac risk Limiting vascular calcification and arterial stiffness is crucial here. Number 3, phosphorus control is a marker of adherence. It tells the transplant board that we're going to do a great job when you give us a new kidney. So it reflects engagement with your diet, and it reflects your willingness to take your medications right. It reflects your motivation. Next, a predictor of transplant readiness. It signals your ability and willingness to manage a very complex care requirement, to overcome a challenge. And finally, it will reflect your post-transplant stability. After you receive a kidney transplant, if your phosphorus and parathyroid hormone are well in control, you're going to have a better outcome. Remember, phosphorus control is more than a number. It is a window into outcomes. So this is the end of my talk, but I would love to answer any questions that you might have. Thank you very much.
Thank you, Dr. Fadem. And yes, we did receive some questions from our audience leading up to today's program that I would now like to ask you. The first question is, what should my phosphorus level be if I'm trying to stay healthy and transplant ready?
I think that we should try to keep our phosphorus between 3.5 and 4.5. And we can easily do that with diet control, but sometimes binders will be necessary.
The next question we received is, how often should I be checking my phosphorus levels and what should I be looking for in my labs?
In dialysis patients, your phosphorus levels are checked every month, and the dietitian and perhaps your doctor will go over these values with you. Before you start dialysis, if you're in stage 4, you're generally going to see your doctor between every month and every 2 months, and your doctor is going to be checking your labs at that time. And if your phosphorus level is too high, he's going to do something to help control that.
The next question is, what are the biggest hidden sources of phosphorus that patients miss?
You would be surprised, but processed foods such as meats, lunch meats, you wouldn't realize it, but they have phosphorus in them. Even certain foods, smoked foods, and there's a lot of foods that have phosphorus in them that's added as an emulsifier. Because if these foods are frozen, then when they thaw out, then they're going to because the cells have been fractured, and they have water in them. Some of that water that's going to leak out is going to have a lot of flavor in it. So by adding an emulsifier like phosphorus, you can protect the flavor in that food.
When do you decide a patient needs a phosphate binder versus just diet changes?
It's very challenging to stay on a diet. Several patients have tried to do it. And some have been successful, but most aren't because it's a very rigorous diet. You almost have to eat only a pure plant diet, and you have to limit any types of foods that have additives in them. So it has to be almost a fresh plant diet. Don't forget, additives are prevalent in just about everything you eat. You'd have to shop in a totally different section of the grocery store to really stay on a low phosphorus diet. And unfortunately, as your kidney disease progresses, the FGF23 doesn't work as well, and your phosphorus level creeps up. So it's by the time you need dialysis that you will need to be on some sort of binder, usually.
Does managing phosphorus looks different before starting dialysis compared to after?
Yes, it does, because before dialysis, you may have enough FGF23 to help eliminate serum phosphorus. But after you start dialysis, generally your FGF23 is still high. In fact, it's even higher. But because your kidneys aren't eliminating the phosphorus, it's accumulating in your body. And so you need more binders generally when you start dialysis. Most patients before dialysis don't necessarily need a binder, but they sure do afterwards.
And the last question for you, what's one thing you wish every patient understood about phosphorus and transplant readiness?
Well, the most important thing is don't just watch your diet because you want to be ready for a transplant. That's a very, very important reason. But the most important reason is that it affects your life. It affects longevity, it affects your mortality. If your phosphorus level is too high, it's going to cause your heart to become weaker. It's going to cause you to have arrhythmias. It's going to cause your bones to become weaker. And all of the things that you enjoy in life are going to be compromised. So try to control your diet, particularly your phosphorus, to keep yourself healthy. There are other things that you might want to control as well, your salt intake, the acid base content. It's not just phosphorus alone. It's a lifestyle commitment that you really want to make because it will pay off.
Dr. Fadem, we appreciate you answering those questions and for your presentation on managing phosphorus and being transplant ready. I also want to thank Paul Conway for sharing part of his kidney journey and the results of our flash survey. For tasty kidney-friendly recipes, check out AAKP's Delicious Recipe series. The AAKP Delicious program offers over 100 kidney-friendly recipes designed to help you prepare healthy and delicious meals that align with your kidney diet. Recipe ingredients can be modified to fit your specific needs. Be sure to consult your renal dietitian if you have any questions on how to incorporate any of AAKP's recipes into your daily diet. Purchase all 8 editions of AAKP Delicious online at aakp.org/shop and start your collection today. Please also visit the Hidden P in Kidney Disease.org to access more phosphorus related information and resources you can download at no cost. Be sure to save the dates for AAKP's 2026 Awareness Days. On April 5th, as we mentioned, we observed National Phosphorus Awareness Day, focused on helping patients better understand phosphorus, how it affects bone and heart health, and practical ways to manage it through diet and treatment. On May 1st, we recognize National High Potassium Awareness Day, raising awareness about potassium balance, symptom recognition, and the importance of timely lab monitoring and treatment adjustments. And on June 3rd, we recognize National Itch Day, highlighting a symptom that is often overlooked but can have a significant impact on quality of life for people living with kidney disease. In addition to these awareness days, AAKP supports patients year-round through our Every Patient Safe campaign, which provides education and tools focused on emergency preparedness, infection prevention, and patient safety. To learn more about these awareness efforts and access resources, visit the AAKP website. We are excited to announce the dates of the AAKP Public Policy Summit. The 8th annual AAKP Public Policy Summit will take place on July 23rd at the National Press Club in Washington, D.C. Registration for this free event is now open and a virtual option is available for those unable to join us in person. Please continue to visit our website and follow us on social media channels to keep up to date on the latest events information. And finally, you can visit our special AAKP On Demand webpage at bit.ly/AAKP On Demand to watch a number of great presentations and webinars, all available on demand from our 2025 events and programs, as well as our 2026 programs as they occur. You can also visit the AAKP YouTube channel at bit.ly/AAKP YouTube for more great content. We'd like to extend our sincere thanks to our outstanding speakers, Paul Conway and Dr. Stephen Fadem, for leading us in such an engaging discussion on high phosphorus. We're truly grateful to everyone who joined us today and our generous virtual event sponsor, Ardelyx, for supporting this year's National Phosphorus Awareness Day efforts. Thank you again for being part of today's event. We hope you have a wonderful rest of the day.